It's now my pleasure to introduce our speaker today, Trish Tulloch. Trish, I'll hand it over to you.
Oh, great. Thank you, Alicia, and welcome, everyone. Delighted to be back with you. This is, of course, the third webinar in a four-part series for emergency preparedness for the outpatient healthcare settings. And today, actually, we're talking about communication plans and responses. So I like to start with the webinar questions from session 2. You know, session 2 we talked about policies and procedures, and you're a very diverse outpatient healthcare group. So policies and procedures are similar maybe 90% of the time, but then each of you have different protocols that you're responsible for depending on your setting. And of course, the question was that an entity asked about, is it really necessary to have detailed policies and procedures for all the risks in the HVA? And we did the HVA in webinar 1, and I know that many of you are in the process of updating or planning to update your annual HVA to update your plan and your policies. This was a multi-site entity that had emailed the question, and they asked about different risks at different locations. And of course, some of you are local, others are regional or state, and then of course other folks can actually be part of a national chain. So this is going to be up to you. Most people share their policies and procedures. You're local or regional if you're multi-site, and you want to address your top 10 risks. I know many of you have used a version of the Coalition HVA, and there's policies available on the website as well. And then, of course, if you have multi-sites located in different geographic areas, then you may be splitting those out on a shared file and have some different policies and procedures to address those. So obviously, volcanoes, for example, are not in our region, and you may be part of a larger entity that has landslides or volcanoes like our friends in Hawaii now. The other question that came up, and I didn't answer it during the program last time, was, will these programs be archived? So they are being taped, and they will be archived, and the Coalition will send out those links to you. You actually already have those. And then you'll be able to have staff. You know, I know you're all very, very busy. On top of it, the tropical weather season has started, and hurricane season starts, of course, tomorrow. So I know you're busy, and there may be better times that people can access the information and listen if you find that valuable. So thank you for participating, sharing. I love to hear your questions. I know the Coalition will be sending out a satisfaction survey as well after the fourth webinar, and that's next Thursday on testing and exercising, June 7th. And then, of course, if there are any questions from this webinar and we don't answer them during the program, then we'll ask that we'll answer those questions at the beginning of the next one. This will be covered under CMS. Does it apply to outpatient clinics? Okay, so we'll talk about those, the outpatient clinics. So we'll talk about that. I see that there's a question related to outpatient clinics, and I thought that I answered that the first time, but we will go back on that. And absolutely, outpatient clinics that are billing, the final rule from CMS for emergency preparedness applies to 17 providers, and those are the providers that bill Medicare or Medicaid for services provided. So if you're an outpatient clinic and you're billing Medicare and or Medicaid for those services, then the final rule applies to you as well. So the goals today, of course, are look at communication plans. Now, your coalition has a communication plan, and of course, you do built into your emergency preparedness plan. So you want to be sure that you're doing a 360 on it. You're going to update your HVA and your plan and policies, and one of those areas that's critical is your communication plan. We'll look at the incident command system and activation, essential functions, and also communication across settings, because some of our outpatient providers have to accommodate for sheltering in and evacuation, and what are the different variations for communication and tracking staff and patients and caregivers to those outpatient providers. Now, my hope is that you did access the file on that lower right-hand side. I know you might not want to print up the slides, and I understand that, but there's a second PDF with tools, and I'm going to reference those tools as we go through today. So I'm hoping you can take the time just to print up those 5 or 6 pages so you can reference them as we go through some of the topics today. Now, you're all experts on this phone call, and I understand that. We learned so much from all of you, not only in Florida, but Texas and other states, upstate and down in your region, regarding the hurricane, tropical storm, and flooding in 2017. And so many of you and your community partners built on many strengths, because we learn every time we go through not just a test or an exercise, but an actual hurricane or storm. So we found that many healthcare providers, including outpatient providers, used many innovations, particularly for staffing just-in-time teaching with patients and family members so that they would be up to date. They'd have their supplies and medication and be able to do perhaps their own wound care and even some of their intravenous medications. Housing was a challenge, and there are some wonderful stories during Hurricane Irma where, in preparation, some of the healthcare agencies, including home care agencies, actually evacuated their patients in evacuation zones to hotels, to different locations to provide services in one central location. Of course, mobile apps is another thing that we'll talk about in communication planning. Some of our home care providers in Florida, when they lost their cell service, found that mobile apps such as Zello to convert to a walkie-talkie was helpful to them. So we'll talk a little bit more about the mobile apps. Of course, sometimes when your cell phone is not working, your text messaging is still working, and it's always helpful to remind staff of that. We learned that those agencies who really trained, tested, prepared their leadership and staff for an emergency, really exhibited strengths, and the community and patients were really grateful for them. They proactively staffed, and they could meet patients' needs. We found, of course, many opportunities, but the local, regional, emergency management and coalition communication was very strong and very helpful. And those messages were really aligned between state, federal, state, local, and regional emergency management. So that was helpful in the long run. We had many opportunities. And so I know that as members of a coalition, you all have worked hard to strengthen those capabilities. Power sources was a major, generators and power source was a major challenge for us. Of course, our special need programs, we know that we were overwhelmed in our special need shelters, and the pre-registration was great, but we were overwhelmed because of the magnitude of the storm and what we saw happening post-Hurricane Harvey, during and after. We did learn that we need to revisit communication plans locally, regionally, but within our organizations to build these robust multi-tiered or multimodal communication capabilities, including mass notification. So we're going to explore that a bit more. Supplies, equipment, oxygen, durable medical equipment, those were actually challenges. I know that many of you participated in accessing those, addressing supplies and oxygen because of the length of not having power remained a challenge. Special housing and getting people home once the event was over. Those that didn't have power, of course, that elongated and certainly stressed our system and staffing for those shelters. Now, in terms of home care agencies and hospices and PACE, the challenge really was with home care agencies, our updated current contact numbers, that we found it was problematic in reaching out to them as our community partners. Could they resume care when patients went home from the shelter? Could they help cohort patients and provide additional staffing in the special needs shelters? So that remained a challenge and certainly an opportunity for improvement going forward. We urge all of you, all outpatient healthcare providers, to update your emergency contact information. Is it current? Do you have the exact name and number and email of those folks, not only in your coalition, but local emergency operations centers, regional, of course, and statewide, and then to participate in the Florida Health Stat. Of course, that health commerce system is critical for communication and updating. And I know that it's not mandatory in Florida for everyone to participate in that, but we would encourage you to participate because that's a great place to get standardized, updated communication in a timely basis. Now, in some states, of course, they require participation. So in New York State, if we're an outpatient healthcare provider, home care, hospice space, we have to participate in our health stat program. And in that area, of course, they survey us on that because they electronically track that, and they also require our surge capacity. So they do testing and exercising with that, and it's often a frequent citation. Even after a dozen years of requiring it, we only have 70% of our outpatient healthcare providers who are participating in that. So I urge you to participate in that if you haven't in the past. So consider this. We all know that time is absolutely critical when we have an event. The pre-planning, if it's a planned event, coordinating and informing our community staff, our patients and their family members. What can you do to automate your processes, to update your communication plans? Can you take a step back this year when you're doing your update and look at your modalities and see where do you need to streamline and deep dive into your communication plan? Do you need to extend your alternate and actually update your staff and your patients and your coalition members of how you're doing that? Are you using SMS, emails, and what about social media? Facebook, Twitter. We have found websites, Facebook, Twitter, those have been very, very successful, particularly when power is off and network goes down. So really look at your communication plan and see if there's anything else you can do to drill down and improve your communication plan going forward. The fact is that we have many common challenges during an event. The rumor mill is probably the worst, isn't it? And we've all been on the receiving end of that. Even if there's an emergency that is just within your organization, let's say that it's not a hurricane or a flood, but you've had a critical unplanned event in your organization, that organize consistent messaging with leadership and staff and patients and family, and how to stop or truncate or eliminate the rumor mill, which can really be harmful. It creates more anxiety, more confusion. So that's a common challenge. I find that multi-site messaging often, we'll have an incident command system within an organization, and the leadership is communicating in a number of different ways with their on-call, down on their on-call line, communication line with staff, and then patients and families and community partners. But so many people are calling in, the lines are tied up, and so when people finally get a hold of a reception or office person, they're miscommunicating an older message. So how do you keep internally your staff updated on a consistent message to make sure that what we're disseminating is the most up-to-date information? Do you use mass notification to do that? I think probably our biggest challenge as outpatient healthcare providers, or one of them, is certainly staffing, because we find that many of the staff evacuate a region, they're not reachable, or they're not able to work when assigned. But also we have outdated contact lists within our agency. So we're going to be looking at that as a policy procedure, because you want to drill down on that. We do recommend that your staff lists certainly have a primary and at least one alternate number, as well as the email contact, and that you update them monthly, and that the designated person in your organization to do that is clear in your communication plan, because outdated lists, staff lists, now of course it depends on your size, but many of our outpatient healthcare agencies have many staff. Some are contracted vendors and some are employees, but they move, they change phone numbers and cell numbers, they don't update the agency, and then when you need to reach them in an emergency, you can't reach them. Particularly if they have a home cell and then a work cell. So it depends on the arrangement that you have. Certainly alternate contact numbers for our vendors, community partners, but for staff is a challenge, and staff readiness, because of course they're trying to take care of their family, their neighbors, and then the agency or the organization they work for actually doesn't become the priority, and that becomes a problem for us. So the 4 provisions under the final rule that apply to all inpatient and outpatient healthcare providers that actually bill Medicare or Medicaid are these 4 elements. And since we're doing the 3rd element, that's the communication plan. Next Thursday, June 7th, then, we'll finish up with the training and testing. As always, I think that CMS did a great job of detailing what's expected in the communication plan, what applies to you, and probably the priority that's different is the requirement that every healthcare provider actually documents their efforts to connect with their regional, their local emergency management officials. And of course, you as a member of the coalition, you're probably, it's like speaking with the choir, because you're already doing these things. But we find that many outpatient healthcare providers are not aware of that responsibility in the final rule. So having that contact list, communicating and participating in testing and training to update themselves is really critical. So that needs to be built into the communication plan as well. So all providers are required to update their communication plan on an annual basis based on your real events and, of course, your testing and exercising. And our roles during the regulation, when you're looking at the communication plan, the goal, the final outcome is to maintain that continuity of care and operations, as well as appropriate staffing and use of resources, ensuring safety and well-being of patients and staff, and then supporting our community partners as well as the coalition. What can we do and do differently to enhance those roles? So our COOP plan, the goal is to remain operational with essential services during crisis. And what are those essential services? The communication and the communication plan really interfaces with all of the essential functions as a healthcare provider. Continuity of care. How do we triage patients? How do we arrange transportation if needed? How do we regroup on our staffing? How do we change our staffing? What's the surge capacity? Do we need to help staff, for example, a special needs shelter? Can we cohort patients in a hotel or in a special shelter so that we can provide services in that shelter? And what about our supplies and other resources that require power? For example, the oxygen, which was and is problematic for many of us. And finally, what's our link in the communication plan to our community resources, our coalition, and all of our local responders and emergency management center? So what are the characteristics of the communication plan? Certainly consistency is paramount, but I would say frequency is more important. So in your communication plan, when we're talking about the policies and procedures and what are the required elements, be sure you identify the who, what, when, and how, and include the frequency. So updating your staff contact lists on a monthly basis, who's doing that, and then how is it redisseminated? You know, it's probably in a shared electronic file, and then we're going to do other things as required by our EP plan. Look at the redundancy, not only primary and alternate communication, but deep dive 3, 4, and 5. What other ways are you going to be communicating when you don't have power long-term or a network, for example? How do we ensure internal consistency within our agency and with our stakeholders externally, our community partners, our patients, our caregivers, and our family, to maintain that continuity? And if our patients change site, they evacuate and they change site, how do we maintain care and communication during those alternate sites? So that needs to be considered. Now, the communication plan by the final rule is a requirement. So that's going to be built into your plan and updated on an annual basis. So I gave you in your tools, the first list I gave you was a coalition collaboration contact list, but you can call it whatever you want. It is required in the final rule as an outpatient healthcare provider that you actually contact your local and regional community partners, not only coalition, but your emergency management partners, vendors, for example. And you can see it's listed right in the final rule: staff, providers, patients, volunteers, and then federal, state, tribal, regional, local, emergency management, and state licensing. So I gave you that sample contact list because what we want to see is who's going to be making that contact list, how is that going to be updated, what's the frequency that it's updated, how often do you call, and make sure that you have the name, the primary contact number, the secondary, the 24/7 contact number, and the email contact number. And then, of course, do a follow-up. I always encourage outpatient healthcare providers to ask about any testing or exercises that they can participate in with the coalition. Now, I see that many of you did very well last year during the 2017 hurricane, and all of you worked at what can we do and do differently. Some of the home health agencies struggled with receiving consistent communication, and I see in some of the after-action reports that others of you noted that they didn't get consistent phone calls or they couldn't get through. So tying up the phones is always a primary issue, and we're going to talk a bit more about that. But take that list, build that list into your EP plan. I know many of you, if not all of you, already have that. And then make sure in your plan you have who's making that contact, on what frequent basis, so you have up-to-date information. Now, second to that is updating your list for staff, internal and external, and that would include contract staff. And then, of course, updating your patients, your participants of your PACE, and family members, caregivers, and volunteers. So PACE and hospice have volunteers, and we need to remain in contact with them. So who updates those lists and how frequently? Now, in your communication plan, we like to see the method of communication with your local and county emergency operations center, the EOC. So you're going to clarify who's the person that does that. Of course, during an emergency, we know the incident, the ICS system really clearly defines that communication with the commander. But, you know, on a regular basis, in your agency, who updates that information in a non-emergency time? Now, during an emergency, how do you share medical information? How do you contact them? Is it via email? Is it phone conference calls? We know mass notification go out, and conference calls are very helpful. And then how do you share information with your patients, staff, and family members? Now, if you're hospice or if you're PACE or home health, we know that you're required to develop their emergency plan on admission and update that on a regular basis. So they have to have an emergency plan in their admission packet with all the contact numbers and how you'll be communicating with them. So you may be putting your phone number there, and if the phone lines go down, we're going to use our website, for example. So, and some of you have mass notification systems, so it really depends on how you're primarily communicating. Others of you, of course, we all use the radio and list our 1 or 2 AM and FM radio sites that we disperse public information if other systems go down, like phone systems. So the communication plan essentials then. Your employees, you need a primary and alternate call down list as well as email. And remind your staff you're going to update that on a monthly basis. That's an electronic update, but we know that you have to actually do your you're going to have to print a hard copy, and that has to be done if you lose network, EMR, and cloud-based, that you'll have to have a hard copy printed up. So we have agencies who are updating their employees and their federal and local emergency management monthly, but their contact list for their patient roster, and that's tool number 2 that I included for you. So if you look at tool number 2, it says sample patient roster format, and it has the information that we need, particularly the emergency contact name and phone number. And it's also so helpful to have an alternate phone number. Now, if you're already on an EMR, and many of you are, an electronic medical record, that will roll into your patient roster. Then you'll be listing their priority classification number 1, 2, 3, and their transportation level as well, and any special needs that they have. So patient lists or patient rosters are updated weekly, and that should be indicated in your communication plan. There should not be blanks in the EMRs or blanks on your rosters in terms of contact numbers or classification and special needs. And sometimes I see that staff are so overwhelmed, I'm not making an excuse, but they're so overwhelmed with documentation that they don't understand the critical importance of having that information. So we'll update that weekly. That will be in your communication plan, and then you'll be printing that up. And that a hard copy will stay weekly updated with your emergency kit that's in your outpatient clinic or outpatient center or home care agency. You'll also have a list of your physicians and vendors. So you'll have a quick reference list, vendors, suppliers, and DME, so you know exactly those. If you don't have and you can't reach them, what are alternate numbers or alternate ways to access. So your communication plan then and policies will detail how you activate and who activates, managing resources, security, safety, of course, management of staff, and continuity of care during the event. So we want to just make sure that everybody's aware of the Incident Command System, which is the ICS. Of course, this is a system that's well known. It's a standardized on-scene all hazards incident management concept. It envelops and integrates the communication plan to coordinate response. So we know it well on the local, regional, state, and federal level, but this ICS can be used internally in your individual organization as well. It really integrates your organization for coordination and goal, and it organizes the communication and goal setting. So I think that you'll find that that's very helpful. So if you don't have the ICS written in your emergency plan and integrated with your communication plan, that's what we would recommend you do. The ICS is a best practice, of course, and you can go on the FEMA.gov website, certainly access their information, webinars, webcasts, and materials that they have to learn about it. But it ensures your safety and achievement of goals and efficient use of resource. And of course, it's using the National Response Framework. So there's a legal basis and a regulatory basis for its use as well. But we can use it for planned events like our hurricanes or tropical storms or ice storms, but also our unplanned events, our man-made events. So if you have an explosion or a bomb threat or an active shooter, the ICS, implementing the ICS for emergency management and communication is very helpful. So in a nutshell, you can see that the command, really the command individual identifies the goals, objectives, and priorities, and then it breaks out to the operations, logistics, planning, and administrative finance. So what we find helpful in emergency plans is that you actually detail the job role or description of the individuals under each of these ICS items. So it's clear what their roles are when you activate the ICS in an emergency event. So lessons learned: if we don't use the ICS Incident Command System, then we really do have a fragmented system. It's not as efficient or systematic, and there's really more confusion and poor communication if it's not learned. So the priorities for the ICS, of course, are continuity of patient care and safety of staff and patients and everyone involved, community members, incident stabilization, and of course, property preservation. So those are goals that we clearly want. So you will want to name your incident command structure. So it should be easily available to you who does what and what's the succession plan or alternative if those individuals are not available, because they'll be coordinating your response plan and managing your communication plan to ensure consistency as well as consistent messaging and frequency of those messages. Now, for some reason, this slide's not working, so I'll just continue. But in your incident command, you'll name the leader. And what we like to see is that you have the primary leader. Sometimes it's the CEO, safety officer, administrator, and then you're going to name alternatives. Usually three deep alternatives. The administrator's not there. It's going to be the safety officer. The administrator and safety officer aren't there. Then you're going to name the third, the assistant director. So you want to go 3 to 5 deep on each of these areas, okay? And that will be in your EP, and that will drive your communication plan as well. Now, your operations planning, logistics, and finance, you're going to name those people as well. So you can see, and I'm clicking on it, it's not working, but you can see the helpers will, of course, then be your public information safety and liaison officer. Some of you are saying, I know, Trish, we're so small that one person is doing 10 of these positions, but you really want to scrutinize, and it is size dependent and site or multi-site dependent. I do understand that in the real world. Of course, the operations are really the doers, the people that are implementing the plan. So even though your incident commander is working on the communication local, regionally, they're ensuring that you're getting the messaging and communication, that you're distributing that and moving that out to an operations. How are you prioritizing staffing and staffing? How are you prioritizing patients, and are you preparing for evacuation? Planners are helping, of course, and working with the logistics for supplies, contacting the vendors as needed, and looking at what else is needed, such as transportation if we have to evacuate from the evacuation zone. And of course, your finance administrative sector, those are the people that are really tracking closely the documentation, the 1135 waivers, the changes that need to occur internally to track the care you're providing and where you're tracking that care. So those essential functions then are operationalized with the ICS and integrating that communication plan. So I know that your coalition has some resources available for tracking staff and patients, and we know that outpatient healthcare providers such as home health, hospice, and PACE have to actually track staff who are in the field visiting patients as well as patients. So if patients and staff don't answer and you're in a mandatory evacuation zone or during an emergency, we are required to notify our local emergency operations center, and that is built into your policies in your plan. So what tracking methodology do you use? We all have electronic, but if your electronic goes down, how do you track your patients and how do you track your staff that are out in the field or been deployed to a special needs shelter, for example? So many agencies then, and I haven't actually looked at the coalition resource, but I know that they have one, have a tracking sheet very similar to this patient roster, but it's a staff roster. So on a daily basis, who are the staff in the field? Where are they located? I know that there are some electronic systems and EMRs, and that some agencies are providing those cell phones and GPS trackers so they actually have access to that on their maps. I would say that's the minority of healthcare providers, however. So in those cases, you might have to manually do it with your office staff under your operations. So the supervisors and managers then are tracking staff and tracking patients, of course, when we do the call down. How are you prioritizing patients and then communicating the managers and supervisors, calling out to staff and preparing them for evacuation or sheltering in? Your alternate site activation should be built into your plan. I guess when I look at emergency plans and work with agencies, often I see that they don't designate in writing their alternate site, and I would encourage all healthcare providers, but including our outpatient healthcare providers, that we at least consider having that alternate site in writing and updating staff ahead of time and not holding on that activation. So those agencies that have done that have been very successful. Now, I know it's easy for multi-site providers to do that. So how do you prepare staff, communicate with staff and your patients and caregivers? And then, of course, how do you address those population with limited mobility, transportation issues, and how do we continue to provide care for those folks? So your EDP activation, of course, we want to use the staging terms that we use with FEMA, and most of you are aware of the level 1, 2, 3, and 4. I think it's helpful when you're orienting staff and doing your annual updates with leadership and staff to remind them about the ICS system and the roles, and then the staging terms for activation so that everybody's aware of you're on alert, standby, call out, or stand down. It's important to have common language to easily be able to communicate. Now, how do we communicate with patients and families, of course? We're going to use not that exact language, but prepare them, and you've all done very well during the hurricane. We prepare 3, 4, 5 days ahead of time so that they have their medication, their supplies, and if they're preparing to evacuate, they've pre-registered, and we have transportation lined up as well. So your communication plan must really interface with and take into account all special occurrences. That would include, of course, planned and unplanned. And again, I think you all do very well. I know that you've critically done a 360 review after action reports after each of your hurricanes, and particularly Hurricane Irma, and you've looked very closely at what you can do to ramp up and improve your communication and your logistics. We want to be sure that we're including the unplanned events as well. What would we do and do differently? So for our patients and caregiver and family readiness, we're required as outpatient providers, home health, PACE, are required to have a written emergency plan with details in the home and in the medical record. And we find, because I'm in the field quite a bit with providers, home health, hospice, and PACE, of course, and we're finding that staff aren't aware of the importance, so they aren't filling in the blanks on the emergency preparedness plan. They're not clearly communicating with patients and families about their options, alternatives. Maybe there's been an evacuation route change, or the shelter. How do they arrange transportation to the shelter? So you want to make sure that your staff are up to date, and I know most of you have done that in preparation for this hurricane season. It's just a reminder that even if you have staff that are long-term, sometimes they forget the details that need to be on that emergency plan. And then, of course, how you're going to communicate with patients and family members, what radio station to listen to if they're sheltering in. And if they lose power, do they have a transistor radio? What station do they listen to so they can hear updates from the community as well as the agency? So what are their roles in the call down? What's your succession plan in the ICS? And who's responsible for that communication tree and call down? So other vital documentation for your communication plan is what is your alternative if you lose, as you have, internet, electric, and computers. Many of us depended on our cloud, and then accessing the cloud became problematic for some of us. So where do you keep those backup records if you need it and you don't have or can't access your electronic, your financial, your vendor list, your employee list, and all of your local emergency contact and coalition numbers? So other documents that are helpful then is to be sure that you have your DME, pharmaceutical, and your memorandums of understanding, your MOUs. I know that you've looked at them many times, and many of you have tried to arrange, for example, for your hospice or your compromised patients to go into a hospital or a SNF and have MOUs. And those have been difficult or challenging during the events that you've had. So I think it means regrouping on what can we do, what contracts can we update, and what can we do for our functionally impaired. So the special needs shelters are helpful, but if you're an outpatient healthcare provider, then what's your responsibility for looking at surge capacity and being available to staff those shelters? Is there a way to look at that differently and look within your local region and with your partners? I know that you've worked on staffing with one another. Is there anything else that you can do to really make that easier and better prepared? So communication's critical. What can we do internally? What can we do externally? What about those traveling and working in the field? And what about our contracted staff? So that multi-tiered or multimodal communication, if you're looking at your communication plan, are you really clear about 1, 2, 3, 4, 5, 6? And are your staff clear about those modes? What are the primary, secondary, and tertiary modes? I know some of you have dedicated landlines. All of you have cell phones and websites. Do you? Because we saw last year that the use of Facebook and website updates were very helpful. Remind staff that texting often works when cell phones don't work. And what mass notification systems do you have in place? It is always recommended that you have your communication templates in your groups already done. So probably those of you participating have done that you've already set up templates for your mass notification and template communication for your radio stations as well. Have you built social media into your communication plan? Because we found that Twitter and Facebook were our primary means of communicating. Certainly, many of us did in Harvey and Irma, and we learned a lot about that. The mobile apps, there are many, many mobile apps, and if you're providing a cell phone to your staff that are in the field, what mobile apps are available and should be built in or considered for your communication plan? Of course, we heard from many providers in Florida last year that Zello was an app that many of them used, so that they converted their cell phones because their cell phones weren't working. They had the app. That converted them into a walkie-talkie. Now, there are many, many mobile apps to convert to walkie-talkie. So it's often useful to take a look at that technology. Many of you have done that already, but I'd ask you to do a 360 on that again, because that's helpful to staff, field staff, who are out in the field and mobile with patients and family members, and you actually lose cell phones. So what social media do you use, and where can they be referred to in your communication plan? So your considerations are vital. Certainly the infrastructure to expect the unexpected, the workflow technology to automate communication, and to pre-write those communication templates for your radio announcements, as well as your mass notification. Some of you already have your groupings. For example, your ICS, your leadership, your internal communication, your external with field staff, and then your external with other agencies or partners, coalition partners. So pre-program those templates, then you need to quickly update them and do that. What frequency will you provide that communication to internal and external partners? What staff availability and scheduling? You know, probably in some states we're required to staff up and provide that staffing to our coalition members, local emergency management, and our local state health departments. So we're required to do that, and I know that's not a requirement in Florida, but I know that all of you and members of the healthcare community want to be a part of that initiative. And so if they learn to proactively staff and be part of the surge capacity for those special needs shelters, along with upping our MOUs, that will be helpful. That's just another app that I have on there, but you can go on and look at all the apps. Now, of course, built into your communication plan, I'm hoping that you have looked into the GETS or the WPS cards as well. I would recommend this to all outpatient healthcare providers for the leadership group, that you go on the website, the Government Emergency Telecommunications Service, obtain the GETS cards so they can be used by your leadership in a crisis. You know that the networks, the phones become congested. We haven't been able to make calls or receive calls, and we can't get through. We get busy signals all the time. So your ICS folks, if you can obtain the GETS cards for them, then you'll be able to utilize them and at least have some probability of completing a normal call when it's so congested. The same with the WPS card, the Wireless Priority Service. And you can apply for those and look to see if it works easier in your communication plan to make sure to have those, and maybe help decrease some of that and get you in the queue earlier than later. What are some of the best practices then? Of course, the best practices involve you using communication templates and automated responses with mass notification systems. But pre-planning, and I saw this in many of the Coalition After Action reports, that pre-planning, that your staff are updated on communication, primary, alternate, and tertiary, and pre-planning with your local emergency, Department of Health and coalitions, so that if this goes down, then we move to that. How do you communicate with your internal and external stakeholders, and can you expand your communication plan to include or standardize the use of social media and potentially mobile apps? I know that works for some of you, and I know others of you it's not a workable solution yet. So in the phases of disaster management, your communication plan actually interfaces with every area. That preparedness, response, recovery is absolutely critical. And we've seen the difficulties in Puerto Rico because without power and without infrastructure, that disruption in communication does put the life and safety of staff and patients at risk, as we well know. So you want your response plans to be very specific, but your communication plan to be deep and to envelop both planned and unplanned. Now, I find that the greatest gaps that we have found is that in training and testing and in actual emergencies is that communication is one of our greatest gaps. I know that in Florida, I know the staffing and the supplies for the special needs shelters, that was one of your greatest gaps, and certainly was in Texas as well. But communicating that consistent messaging within individual organizations remains a gap as well. Now, surge capacity is important. Outpatient healthcare providers understand that we're responsible to our community and community partners. So once our patients evacuate to a shelter, it doesn't mean that we wipe our hands of them. Then we look at staffing to support the special needs shelters. So what do we do in our plan, in our communication and our policies and procedures for our staffing plan when we are actually planning an event such as a hurricane and mass evacuation or sometimes sheltering in? So each of us writes in our surge capacity, and it depends on your census, patient classification, and your staffing. And of course, staffing is really critical during those times of crisis. So first and foremost is that patient classification system. And I know we all have all different types, but I'm just giving you some samples here that you want to make sure your staff are updated on, that they're assigning, of course, as they're all doing, because you've been doing that for years, and that they're looking at that critically and making sure that that's up to date on a regular basis, their classification or priority classification level, and then their transportation level. So I gave you some examples. Some people use level 1, 2, 3, and they define it with examples, level 1 being very clinically complex with minimal support in the home. 2 is unstable with some support. Level 3, clinically stable. Of course, they can manage alone, and they, of course, do much better. We label them the green level. If you're in a PACE, we're using color when we're triaging them. And then the backup classification system of transportation assistance levels, or TALs. What do we do in our agencies when we admit them to indicate if there were a planned evacuation? Are they a level 1, 2, or 3, or red, yellow, and green? And of course, the level 1 really means an ambulance or specialized transportation, where 2 can be wheelchair, and a 3 are ambulatory, and they can be evacuated no problem with family, level 2 and 3, and with caregivers, and with planned communication to a shelter. So our outpatient programs in the final rule are required. So our hospice, home care, and PACE are required to build in their plan sheltering in, and how will you communicate when we're sheltering in for continuity of care. We're also required to address safe evacuation. And once that evacuation occurs, how do we continue communication and continuity of care when they're in that evacuation shelter? So as an outpatient provider, we're to build that into our plan and consider communication as well. We're a diverse group of people, of course, so our policies and procedures are going to vary depending on our certification. If you're required to shelter in, as you are if you're PACE or hospice or renal or mental health, then you'll have to consider what's your emergency or standby power. And I know that's a challenge, but having a contract for a generator and looking at that and preparing for that if you must shelter in is required, along with the provision of subsistence needs. So supplies, dressings, medications, folks are coming with that, and then how many days do you have? And I know that many of us prepared for 3 when it was much longer for some of us, particularly in the evacuation centers. So if you're evacuating and you're encouraging your patients, you're supporting them in their evacuation, then you're helping to staff those. You're looking at surge capacity, cohorting patients, and staffing. And of course, we appreciated all the volunteers in FEMA who staff those special needs shelters. What can we do differently as outpatient providers to support our patients in those settings? Now, I listed some survey questions, and I only want to point a few out to you. When you look at the final interpretive guidelines from the final rule, they actually listed questions that surveyors would be asking you. And look down to bullet 4. Does your agency have a communication plan that details multiple communication modalities? And look at the last one. How do you track staff and patients during an emergency event? Those are good surveyor questions. And finally, at the top of this slide 59, does the agency have an electronic record? And if that's not available, what's their secondary source of documentation? So having that redundancy in your communication plan and in your emergency plan with your documentation is absolutely critical. I listed on this last slide some resources for you. I hope you take the time. I know your coalition has some resources that be very helpful to you, along with the FEMA.gov and Asper Tracy website if you need resources or other up-to-date information. Thanks for sharing today with us, and if you have any questions, please feel free even to put them in the chat line now. I'll be answering questions from this program on webinar number 4, which is next Thursday, June 7th, testing and exercising. We'll be doing that at 3 o'clock next Thursday and finishing up. So I'll plan to answer any webinar questions in the chat box then. Thanks for participating and have a great week.